And next up, we have Anthony Barnett and colleagues. Anthony will be presenting on care in crisis, experiences of opioid substitution therapy during COVID. Thanks, Anthony. Or Tony, I should say.
No worries, Kieran. Has that come through okay? Can you see that screen?
Yes.
Fantastic. Well, thanks very much. I'd just like to echo other participants' sentiments and say thanks very much to the conference organisers for what's been a fantastic day thus far. Here are my contact details. If anyone's got any feedback, I'd love to get some tips about theoretical frameworks we could engage in, or any other feedback. That'd be great. I'd also acknowledge that this has truly been an interdisciplinary exercise thus far, and in line with the conference themes, definitely empathy and care are necessary virtues in interdisciplinary research. So there's a really strong evidence base that opioid substitution therapies like methadone and buprenorphine are effective in treating opioid use disorders. But we might say that a lot of that evidence has come from randomised controlled trials, and also public health evidence that really aligns the strict treatment regimen that these treatments involve. So often clients that are on methadone or buprenorphine or other OSTs might have to daily dose at pharmacies or clinics, and this is often associated with stigma, for example, lining up at pharmacies and being identified as dependent or an addict, quote unquote. And also there's often a high level of cost associated with OST. For example, in Victoria, for people accessing daily dosing, there might be a daily dosing fee, which for people on Centrelink can constitute 20% of someone's income. So we might ask, well, what does this mean for COVID-19? What does this mean when COVID-19 came in early last year? Well, I guess there's been different arguments and different views. Obviously, the clear one is that COVID-19 and lockdowns and clinic closures might have created further difficulties for people on opioid substitution programs. However, it's also been speculated that we've really got a chance to remake care for the future, and that the easing of some of these strict rules has allowed, for example, more access to takeaway doses, has actually led to a positive. So I guess this has remained speculative, largely speculative. Research exploring the actual experiences of people in care in OST programs has been sparse. And you might say that, there are challenges around exploring those concerns. The COVID pandemic is very fast moving. However, for researchers to, mobilise and explore people's experiences, that can often take a long time. Perhaps one way to ameliorate that is to do research in online communities. In online communities, people are discussing their experiences in real time, if you like. So that's the background of the current study. And the aims are twofold. Firstly, to explore clients' experiences of care during COVID-19. And also, and this is where the data scientists come in, to critically reflect on a novel methodology to analyse a large qualitative data set. And I'll get to the methods shortly. Now, some of the conceptual tools that are guiding the analysis, and this has been discussed a lot today, so I'll just keep this brief. But often, one of the dominant narratives within addiction studies is that care is constituted only as beneficial or nurturing or appreciative, really irrespective of contexts. So by complicating this straightforward construction of care, we've drawn upon some critical theory that views care as relational, situated, and unstable, if you like, made through everyday practice. Also, the care is constituted differentially, so sometimes supportive, but also at other times oppressive or even pernicious, dependent on context and a configuration of a whole range of actors, whether they be human or non-human, such as policy, time, place, and so forth. So just to cover off the methods, so the setting for this study, we wanted to explore people's experience in online communities of opioid substitution therapy. And so we've done this by looking in the Reddit platform. Now, many of you will be aware of what Reddit is. But there's hundreds of thousands of different communities or subreddits that cover everything from sport, news. For this particular study, we've looked at 4 subreddits that are to do with opioid substitution therapy. So just in this example, we have an example of a subreddit on Suboxone, which is a type of OST. It's a community to provide, or at least promises to provide, a place for discussion on OST and other forms of buprenorphine. Welcome to all, whether it be short-term or long-term usage for medication-assisted therapy and so forth. So just to cover off some of the attributes of this particular community, it's about 10 years old with over 16,000 members. Most of whom are in the US, and yeah, so we looked at 4 particular subreddits. Now, just strap yourselves in while I attempt to explain this algorithm, but I'll do my best to explain it in what I've come to realize is still quite lay terms. But the method that we're using and reflecting on in this particular study is called topic modeling. So if we just draw our attention away from this slide, and the easiest way that I could explain it is if we can imagine that tonight after this conference, when everyone goes home, if we were to record what everyone said, maybe for 2 or 3 hours, and get that transcribed and have this massive qualitative data set, we might think that within that qualitative data set, there are certain hidden semantic structures or hidden themes. So one example might be people talking about how great the TASA conference was today. Other people might be talking about the weather, and other people, I don't know, might just be thinking about dinner. So the idea is that in any massive qualitative data set, there are these hidden topics that can be explored or even excavated if you want to use that term. So relevant to this study, what we did was we looked at 4 particular Reddit communities that were focused on different forms of OST. Overall, they had over 17,000 members, and we did our analysis over 18 months, just taking us back to around the start of COVID in 2020. So there were over 50,000 posts, so it was a big data set. Those were extracted, and before entering the topic modeling algorithm, and this is interesting from a linguistics perspective, there's a certain amount of pre-processing of this type of qualitative data. For example, the removal of punctuation, certain words being removed like conjunctions, joining words, prepositions and so forth like and on, and also lemmatization, so the removal of inflectional endings on words. So removing the endings in order to maintain the original stem or lemma. So for example, injection might become inject, injected becomes inject, and so forth. So there is a certain, it is interesting tracing out this full analysis to see that, some of the meanings is lost actually even before we enter the algorithm. So this list of words, or bag of words it is called, entered this particular algorithm, which was a text mining tool for the discovery of hidden topics, like I said. I won't go into the technicalities of it, but it was a mathematical model called latent Dirichlet allocation. And the idea is that, like I explained before, there are certain clusters of words that are identified. So no meaning at all is made at this point. It's purely a mathematical algorithm that looks at words and how often they appear and the probability of them appearing together. And it's then the role of the researcher to explore those particular clusters and assign them topics. So that's the plan. And what I wanted to do today was give you an example of a specific the output of an analysis that we conducted recently. So this was a visualization that we did of a particular cluster of words, and those are some of the words that were most likely to be attached to that cluster, and this is across the 50,000 posts across 18 months. So I'll just read out a couple or a few: dose, pharmacy, think, script, help, this sort of thing. So we might think at that point, okay, well, at least the words that are being used are around pharmacy and dosing. So what I then did was I was interested to capture some of these individual Reddit posts made by Reddit community members that were linked to this particular word cluster in order to, I guess, dig deeper and gain an understanding of what was actually being discussed. So I thought I'd present this example for the purposes of today. So what I've done here is I've just taken out the Reddit username just for a little bit of privacy, but I am aware that this could be backtracked and found, although they are anonymous anyway. So this particular Reddit forum member had a post entitled "Witness Doses During COVID." And I'll just read this out, or part of it. This is a bit of a rant. Title really says it all. The fact doctors are still writing prescriptions that force patients to go to pharmacies on a weekly, if not multiple times a week basis and witness the dose during this pandemic is insane. When I go to the pharmacy, I have to touch my dirty car keys, dirty car door, dirty steering wheel, go into the pharmacy and touch a dirty pen and then grab the pills with dirty fingers and put them in my mouth. I shouldn't have to put my effing health at risk. Oh, and I've been on subs, so Suboxone or OST, for 4 years. Never relapsed or had a dirty urine once. This is what subs are like in Canada. So here we see really what I was talking about in the background, the strict treatment regimen playing out, doses having to be witnessed, which really implies and frames consumers as potentially untrustworthy, or not being able to follow instructions. And we see that the strict, COVID, the overlay of COVID restrictions and so forth, potentially exacerbating what we might call a site of harm reduction to a site of harm production. So perhaps not, what it was actually originally or framed in policy and so forth. Now, in response to that initial post, I just wanted to capture some responses, and there were over 50 responses, so I'm just focused on a few. But some other community members wanted to share their experiences and how they were different. For example, this person said, "My experience has been completely opposite, also in Toronto, Canada. Since COVID, I am given 3 weeks take home compared to 1 week before." Another person stated, "I'm in Australia and get 20 takeaway doses at a time. We don't have to sign anything at the moment." So we saw, and these were just a couple, but there were a whole range of other different experiences of care, which is really linked to policy, place, and how care can be experienced in different ways based on the context of particular OST clients. And it also reiterated that, care could be afforded in more flexible ways.
3 minutes, Tony.
Thanks for that, Kieran. Beyond affording care in more flexible ways, there are also other types of responses, and this typified how online communities could also act as sites of care within themselves. So for this particular Reddit community member, they responded to the original post. "Damn, while I agree it's a little over the top to witness a dose and going once a week, as long as you are safe, I don't see much risk. Gloves, soap, everything you need to be safe are readily available. I understand being frustrated. I would be if I was in your position. I guess I'm lucky my doctor has been doing it over the phone, normally a 1-minute conversation. I've been seeing this doctor for a long time without abusing his trust though. Canada needs to switch that up." So this was an example of how online communities themselves can provide can provide a setting where empathic care between forum members can emerge. And it also, these types of care, they offered, to share experiences, not only practical stuff about how to dose or consume opioid substitution therapies, but also emotional and other types of support. So just to draw this to a close and reflect on some insights, so hopefully this data has illustrated that care can be constituted in different ways, that it's context dependent, that it really emerges from a whole range of actors, for example, policy settings in local international settings. It also indicated that care regimes can not only give rise to deleterious effects, but can also be less harmful. So, so it was a double-edged sword in that respect. Furthermore, the kinds of empathic care practiced in online communities, they really offer noteworthy examples of peer-driven care during COVID-19. However, one thing you might say about peer-driven care is, I guess this is changing, but in the past, perhaps it hasn't really been valued as such, as possibly being described as informal care, or yeah, peers being hired by organisations and not paid as such. So perhaps that type of care can be appreciated more. Just to provide a critique of the methodology that I've explained. So I guess the flavour, the topic du jour, if that's the right saying, is obviously AI, all things AI and algorithms. But I think this is an interesting case study of there's a risk of using these types of techniques can really lead to reductive research practices. So only looking at word clusters in this specific example would have obscured our analysis into how care materialises, and also could have elided the complexity of the whole research assemblage. For example, the theoretical approach that researchers bring in, and the ontopolitical commitments that researchers bring to the table. So yeah, on that note, I'll leave you with those acknowledgements, but thanks very much for listening.
Thank you so much, Tony. And the linguistics nerd in me loves to hear you use the word levitisation. It's been a while since I've heard that term, so
I thought you might
thanks
like that
for
one.
dropping that in there.
Yeah.
While people digest, I don't see any hands up. You just wanted to ask a little bit more about, you mentioned briefly your critique of the method, and I guess I wondered, and maybe it's just me having an afternoon brain fog, but did the topic modelling approach inform your analysis, and what affordances did it generate, if any, or do you think that your analysis would have been well served with the existing kind of qualitative approach that you took in presenting the quotes? And I do apologise if I missed the kind of key insights that topic modelling was offered, but it seemed to me that that approach in the end wasn't necessarily that useful to your analysis. I don't know if that's a fair assessment.
Yeah, no, thanks for that question. I guess what it's been interesting from a sort of researcher reflexivity point of view for me, because with something that is so algorithmic, if you like, it does highlight that any analytic lens affords certain things and produces certain findings, if you like. So in this particular case, findings aren't out there in the wilderness waiting to be discovered as such, but they're made in and through the analytic lens of the algorithm itself. But that also then invites us to think, even if we were doing, say, a traditional thematic analysis or something a traditional form of qualitative research, even that in itself is an analytic lens that also affords different outcomes. So I guess, yeah, findings are made in and through a whole range of actors, including the analytic lens and the theory we bring to the table. Just very quickly in relation to the last point you raised, I'd say for a massive data set, and we're still working through this, but for a massive data set, with over 50,000 records, I think it is useful, because in another example, we found, particular drugs that people might have been using, like kratom and so forth, as a form of opioid substitution therapy. So I didn't use that example today, but it gave a very quick, broad visualization of what's going on. But yeah, I would be very reluctant to say that it would ever be a replacement for traditional qualitative methods, but rather a tool.
Great, thank you. Thank you so much, Tony. That's answered my question, and thank you for introducing certainly me to that new approach. Others might be familiar with it, but it is great to see innovative new methodological approaches being presented today. And there are lovely resonances across your paper, and Mrs. I really like the way you've both complicated notions of care and empathy and highlighted some of their maybe deleterious or counterproductive effects. So thank you very much for that. We're right on 4, so we might move on if there aren't any other questions. Am